Krishna Prasad right in front of you before the podium. Sir, here's your audience. You can start your talk now.
Thanks, Dr. Anurag. Good morning, and it's a very interesting compilation of videos on a very important topic of femtosecond laser-assisted cataract surgery. Well, people who have it ouch by it, and people who do not use it always have a list of objections to this adoption of this technology. So I think it's A to Z probably covers most of the things. I hope that we will, by the end of this IC, will be able to really drive home some very important points in the technology advancement. So I'll be speaking on the how do you manage soft cataracts as well as cataracts of moderate hardness. So this is a case where you can actually see that the capsule is already free floating. So just to take a word on this, there are a lot of naysayers and detractors. We are all surgically very competent. We can do a rexis in almost all the times, and just to do a rexis, just to cut a nucleus, why do you spend money on this machine, and you have to spend on the consumables, which is pretty pricey. Patient has to go to another other setup, and there's an extra time that is taken. So that obviously there are many obvious objections to this. But look at this. It was a free floating. The rexis was already made, a 5 millimeter perfectly centered, very circular rexis, which is not manually possible, even though you can come close to it. But the point is not about how we can make it in. I am a very good surgeon if I say I have only 0.1% complications of my rexis. But for that one patient out of 1,000 patients of mine, it's a 100% thing. So it's basically as we move forward, okay, not taking our individual cases in consideration. If you take the majority of surgeons, see our patient, look at the patient perspective, they end up with sometimes people with lesser surgical proficiency, or the clinical situations probably more demanding. They may not have the enough expertise to handle such situations. Then for the patient, a bit of automation, a bit of, if you can take the human errors out of this, so then that can make up for the incompetence or maybe a chance event of things going wrong. So this is where the flags kicks in here. So the rexis is already made, so which makes my job simpler, and I am now trying to separate the nucleus and the epinucleus from the thing. So basically is already some amount of hydro delineation or dissection that has happened. The comodoxide bubbles have already created some kind of a loosening, and now you already have a nucleus which is cut into 6 pieces. This is what I use the CHOP, I use the LensX platform. Now I've also started using the Zima platform. So this is where it's already pre-cut. So it's just like how you separate your pieces of a pizza, which is looks little daunting for beginners, but probably when you start eating more pizzas, you will understand it is not that difficult. At the same time, without cutting a pizza into 6, it's very difficult to eat a pizza. So once you separate them, once you just need to separate, you don't need to really do anything much. It's already cut. You just need to separate them so that the pieces it becomes so simple, so easy. Because nucleotomy, how much ever edited videos we show in the conferences, that we marvel at those nucleotomy techniques which happens in the jiffy. But at the same time, there are a lot of videos that you can actually show where you get into trouble, at least in beginners trying to do the nucleotomy in all different types of cases. So this takes this error out of it. This take this chance events out of this, so that you can create a safe a surgical milieu. You can really offer that justice, or what I should say, an equal level playing ground for all surgeons, so that you can have a much safer surgery. So this is where it's slightly a harder cataract, where you can see the nucleus is. So here this delineation, if you can slightly increase the energy in your energy settings, you can still get a very good cut. So basically there's already a default energy setting in the machine. For a soft cut, you can actually go down. You don't have to really overexpend the energy. For a harder cataract, you can definitely have that option, just like you increase the phaco power or the OZIL percentage. Similarly, you can also increase this your femtosecond laser settings and use this. So this is a soft cataract. See, this is just a demonstration. You can have different ways of nucleotomy. What I showed was a 6 pizza cut, which we call it as chop in LensX. This is where a frag, where you make multiple cubes. Okay, just I use the word pizza. I can use probably a dokla here, a mini cubes of your whatever dimension that you want in 3 dimensions. So you have small cubes, which basically softens the entire nucleus. Well, let me tell you, for beginners, a soft cataract is not easy on a lens on a flax platform. It is actually a moderate hardness cataract is a very ideal situation where it's brittle and it really gets cut and very easy to delineate the pieces. A very soft cataract, you should make sure that you reduce the energy. At the same time, preferably make a chop rather than a frag for beginners, so that you can actually easy to pick those soft pieces. Because if it's a very soft cataract, if you can use this frag or even chop, you can actually, since it is already cut, the whole nucleus can be sucked out. You can even create something like a phacoaspiration situation where the whole nucleus, because of this pneumodissection and delineation, as well as your additional hydro procedures, the whole thing becomes mushy soft and can be sucked out very easily. So this is a smaller pupil. I think we have a talk on this. What I'm trying to just show is that you can actually catch each piece, bring it to the center. The only problem in a soft cataract is the rexis size, which normally, the pupil size determines the rexis size here. You cannot really have a way of expanding the pupil and doing a femto in most cases. So obviously you are limited by the rexis size, but still even a 4.5 millimeter rexis is good enough in such cases where you can really bring the pieces to the center, because you don't have to really go to the end and try to chop. The complication rates come down very drastically because you have already had cut pieces there. You just need to kind of latch onto it, bring it to the center in the safe zone, and emulsify it further. So but at the same time, I just want to show, to make my point. See, this is a case which I have made my fellow to operate. Of course, not just because of this IC, it just happened. I had done the LensX. So this is how you take this learning curve out of this. This newbie surgeon is operating on where I've made a 6 cuts in the nucleus. It's a pretty good case for a beginner anyway. So this is where and it's not very difficult for a new surgeon to just, so this is what I'm saying. It takes the difficulties for a person if he's trying to make a trench and make a soft, stop or chop or a direct chop. Obviously, it would create some new challenges for him. See, he that he's very tentative, very provisional, and his moves are not very confident. But nevertheless, you can still see that how he's doing his job well. You can see the little tremors on the left hand. So once he is able to pick it up, and everything falls apart. The pieces start, disintegrating because there is a space for the fragments to fall apart. So this is almost an unedited video of a new surgeon. I mean, doing it for the first time. So this is what I really want to say, that from the patient perspective, obviously the human errors are much more out of the equation. So basically, a moderate nuclear hardness is an ideal situation for beginners at least. See, the idea is that once you normally there is a small fear in the beginners that if you do too much of hydro dissection or a vigorous hydro dissection, because already the kind of lens is, little become saturated with those bubbles, there's a possibility of a PC rupture or PC tear. I think we can ask other panelists, even Dr. Sri Ganesh is here, we can probably discuss this. So there is always some kind of a less effort in trying to mobilize the nucleus. Or we don't get a free rotation, people don't really rotate. But I feel that unless you get a good rotation, okay, you should not continue, because it may really create some problems on the way. And the depth of nucleotomy, you can actually preset the depth depending upon the lens thickness. So you can really go to the entire, believing that the minimum required protective margin from the posterior capsule, the entire nucleotomy cut really makes jobs much simpler. And does it this surgery makes surgery faster? Is it the speed that we are trying to look at, or it is the safety? I think it is probably both. Even though you spend some extra time, I mean, just before you start the surgery, okay, but keeping the advantages of safety, advantages of the repeatability or the reproducibility of the steps, and most importantly, the human error component. Okay, if you can take the human error component out of the equation, so this really makes up for whatever that extra time that you're going to spend. But at the same time, in a situations like where you have a weak a zonulopathy, or it's very difficult to do a rhexis, like if you have a dangling lens, with all your accessories and great surgical expertise, you may be able to just make a rhexis, sometimes very small, sometimes very close to the weak zonular area. So sometimes you may not have enough adequate margin of the rhexis to really put your capsular hooks. So it makes the entire job difficult, and during the process of rhexis you may damage some more zonules, which is usually the case. So since those videos are very well edited, you may not sometimes see the real story. But here it's completely, I mean, human effort free. You can get your rhexis wherever you want, depending upon you can move the entire rhexis to the actual central location of the displaced nucleus, and without causing any kind of a manual derangement of the zonules. So in special situations, obviously, flax really scores hands down, and should be the thing. Obviously, the technology comes with a cost, but there are definitely ways to really work on that. Thank you very much for your patient hearing. I'll be very eager to hear the other inputs from the other panelists. Welcome, Dr. Arup.
Welcome, Arupda. So for convenience, what we have done is, this is how we would be dividing the session. Dr. Krishna Prasad and the next speaker, both of them use the LensX platform majorly. Then we'll discuss about the machine platforms that are available, and then we go to the other platforms like Dr. Arup Bhaumik, who is one of our co-instructors, uses the Catalyst, and Supriya uses the Zyma Z8. So it'll be interesting if we put it that way. Sir, just one question before I call in the next speaker. I saw that some of your videos had the 2.2 sleeve attached to the needle. Yes. Some of them had the 2.8 millimeter sleeve attached to the needle. All of them had a similar grade of nuclear sclerosis. So what do you decide that on when you're taking out flax? That's number one. Number two is, we know that when we fashion the corneal incisions on flax, the outer lip and the inner lip have different dimensions, and the inner lip is actually wider than the outer by around 0.2 millimeters. So if you are fashioning a 2.8 millimeters incision on flax, it'll be 3 millimeters on the internal side. So do you do that with the flax machine, or when you choose to do a 2.8 millimeter incision, do you go the manual way?
Second question first, that is, I don't use the I have stopped using the corneal incisions.
Okay.
So for the convenience sake, and I really did not find much, even though my cornea department people use it, I have stopped using it for my own reasons. Well, not with any specific intention, just like I just stopped using. That will really lessen my time that I spend at the LensX machine. About the sleeve size, I think Dr. Sri Ganesh is here. He was the one who made me change, because when microcoaxial 2.2 was a big deal, and we really did for years together using that, we were very happy that we were just telling 2 millimeters, even though it was 2.2. And I really had a lot of, some kind of a pride in lessening the incision. But when I had one of his lectures where he himself shifted to 2.8, when the whole world is trying towards going to smaller and smaller incisions, which was the kind of the hype, like he kind of reverted and said that it makes a big difference in the fluidics, which I went and found it for myself, that my surgery is much more safer, faster, better AC depth control, just by increasing it by 0.6, which did not really make much difference in the astigmatism profile or in anything else. There was absolutely no difference in the outcome, but my surgeries were much more kind of faster, and it is it's basically a subjective thing, which I got inspired by him. So since then, I've been using 2.8 sleeve, even though I use all the lenses which can go through 2.2 very comfortably. There is probably in cases where you have a small anterior segment, especially in case of some relatively micro-ophthalmic eyes, I switch to 2.2. But otherwise, in most normal routine cases, I use 2.8. Well, it's a point of individual differences, and people can probably choose what they want to do. It doesn't really make a difference in the astigmatism outcomes.